Okay, sure.
Okay, Dr. Masood, it's yours.
Yes, Doctor.
Dr. Masood, he is a second-year resident from the surgical program in the Oman Medical Specialty Board. And it is a pleasure to have a resident presenting in our meeting. He will present very, very interesting article. It is an upcoming article with a very interesting recently innovated procedure to do like minimal invasive kind of surgeries for pancreatic lesions, and we will let him present his article and let us know and educate us about this. It's yours.
So the slides are there?
Yes, it is.
Good evening, everyone. My name is Masood. So today I'm speaking about the endoscopic ultrasound guided radiofrequency ablation of pancreatic lesions. It is a journal article review. So the first question should come into our minds. Why do we talk about RFA in pancreatic lesions? Because it has already established use in solid tumors like paresophagus with dysplasia, esophageal adenocarcinoma, and hepatocellular carcinoma. But still, we have high mortality from pancreatic lesions. We have limited options, unfilled gap in the management. So can endoscopic ultrasound RFA fill this gap? We know that RFA uses high temperature alternating currents, so expected side effects, pancreatitis, gastric wall and bowel injury, pancreatic duct injury and stricture, bile duct injury and leak, peritonitis. So today we'll be discussing about a review on endoscopic ultrasound guided radiofrequency ablation of pancreatic lesions. This is a review article. We'll do also a critical appraisal of it. So first of all, we'll answer the PICO question. So I divided the population in this article into three because we'll discuss them separately. Population 1, pancreatic adenocarcinoma patients. Population 2, pancreatic cystic lesions patients. Population 3, pancreatic neuroendocrine patients. The intervention is endoscopic ultrasound guided radiofrequency ablation. We're not comparing this modality to other modalities. The expected outcome is the efficacy and safety in downsizing or ablating the pancreatic lesions. So our PICO question is, in patients with pancreatic lesions, adenocarcinoma, cystic, neuroendocrine tumors, does endoscopic RFA effective and safe in downstaging or ablating the lesions? This article was published last month on 1st of February. It was published in Diagnostic Journal. It has an impact factor of 3.2. A type of question, observational. Type of study, systemic review of non-randomized control studies. So before we go to the internal validity of this article, I always like to start with the aim and rationale of the study. So do we need this study? To answer this question, we'll go into a bit of a background. Pancreatic adenocarcinoma population, we'll discuss firstly. So pancreatic adenocarcinoma incidence is increasing. It is estimated that it will be the second leading cause of cancer death by 2030 after lung cancer. 5-year survival rate ranging from 2 to 9% worldwide. For resectable or borderline resectable diseases, surgical resection with a new adjuvant or adjuvant therapy. For locally advanced or metastatic disease, systemic therapy. Unfortunately, 80% of pancreatic adenocarcinoma patients are locally advanced or metastatic disease. Therefore, can endoscopic ultrasound RFA be beneficial in this population? So these are the articles reviewed in this study. So first, the publication started in 2010. They've enrolled 50 patients, and then the outcome was the decrease from CA19-9 from 184 to 47. Then you can see the results in subsequent publications, decrease in tumor size in 38%, successful application in all 6 patients, decrease in tumor size by 50%, 30% mean tumor ablation. We have one study that said 95.5 treatment failure, and the recent study last year, they said there is a median survival of 20 months, tumor progression in 2, tumor regression in 6. So there is a role in RFA, not that much optimistic results. We'll go to the second population, pancreatic cystic lesions. We have two types, mucinous and non-mucinous. So briefly, the treatment of precancerous pancreatic cystic lesions is surgical resection. Surgeries, of course, have high morbidity in those patients, and less invasive modalities being studied, like endoscopic ultrasound-guided alcohol ablation and endoscopic ultrasound chemoablation, not yet proven benefit. Now we're studying the endoscopic RFA benefit. So these are the articles in this review article. So we have started the application 2015. It was a pilot study. They've enrolled 6 patients. All showed complete resolution or more than 50% size reduction. In 2019, 17 patients involved in prospective multi-center trial. 65% showed complete resolution at 12-month follow-up. And then when they followed those patients at 3 years, it showed 40% of them continued to have complete resolution. Recent article, prospective last year, 60% they showed complete resolution. So more optimistic results in pancreatic cystic lesions. Now we're going to the third population, pancreatic neuroendocrine tumors. It has functional and non-functional. Briefly, pancreatic neuroendocrine tumors functional or more than 2 centimeters in size require surgical resection. If patients unfit for surgery, they have a chance of benefiting through endoscopic treatments. So we're in this study, we're reviewing those articles. So started in 2014. You can see that most of the publication complete response runs from 75% to 100%. But be careful that also this review, systemic review article included even the studies with 1 or 2, 3 patients. So can we really make a decision from these? The latest in 2019, this article, it showed 96% complete response. And when they did the follow-up 8 months, they showed 0% recurrence. So to answer this, the first question, do we need this study? So we have pancreatic lesions that are rare. We have a new technique, RFA. It is few studies, underpowered, no randomized controlled trials. So do we need this study? The answer is yes. We need systemic review about all these journals. Now we'll go to the internal validity. I used the AMSTAR tool. This tool was published in 2007 and was acknowledged by SIGN Group for evidence-based guidelines in 2012. So validity of results. So the research question is clearly defined. If no, reject. So in this article, yes, they clearly defined the PICO question and we easily could extract it. Then is there clear inclusion and exclusion criteria? If no, reject. Unfortunately, they didn't mention anything about the inclusion or exclusion criteria. Now by AMSTAR tool, if we should reject and we should not proceed with critical appraisal. But for the sake of discussion, we'll continue. A comprehensive literature search is carried out, if no, reject. Unfortunately, they did not tell us about where they did their literature review, from which search engine, Midline, Central, Cochrane, what language they searched on, only English language or other languages. So it was not clear. And even the methodology section was not there in this article. At least 2 people should have selected the studies. Yes, they said that 3 participated. The status of publication was used as an inclusion criterion. What do we mean about the status of publication? We mean, did they search the published and the unpublished studies? We mean the unpublished studies like from the registry trials or an article that was presented in a conference but was not published. But here in this article, on the systemic review, they did not mention if they searched. They clearly searched in the published, but they didn't mention that if they search in unpublished articles. The excluded studies are listed. No. The relevant characteristics of the included studies are provided. Yes, they provided the characteristics of the patient, the year, number of patients, size of the tumor, and else. The scientific quality of the included studies was assessed and documented. So what do we mean about the scientific quality of the included studies? We mean, like, I brought this from another article in which they said they used the Ottawa-Castle scale, the Newcastle-Ottawa scale that studies the strength of each publication. So scientific quality in this systemic review was not assessed. Appropriate methods are used to combine the individual study findings, like the forced blot, the funnel blot was not there. The likelihood of application bias was assessed appropriately. This we use many statistical methods and analysis was not there. So overall assessment of the study, I will keep this for your judgment. By Amstar tool we should reject, but at best we can give low quality. Conclusion, endoscopic ultrasound RFA is minimally invasive and safe technique for management of pancreatic adenocarcinoma, pancreatic cystic lesions, and pancreatic neuroendocrine tumors. Its efficacy still needs to be stated given the small number size and lack of long-term follow-ups in the report or currently reviewed studies. This systemic review has high risk of bias. The methodology was not mentioned, and they didn't do data analysis. Thank you so much.
Thank you for this nice article review. The floor is open if there's any questions, any comments.
Yes, thank you, Dr. Isa. Thank you, Masoud, for this excellent, I would say, analysis of the article. For a security reason, we blocked the mic, but please, if you have any question, raise your hand or put it in the chat section. In fact, what Masoud presented was just, I would say, like a general overview of what endoscopists can do with endoscopic RFA. Sometimes we have, I would say, competition between surgeons, endoscopists, whether to go for endoscopic solution or surgical resection for like lesions, which probably sometimes limit between whether small lesions or I would say lesions which are undefined. We have that discussion always. We have a question from Al-Warith. I will let him just to speak. Yes, Al-Warith.
Yeah, good evening. Good evening, everyone. Do you hear me?
Yes, yes.
Thank you. Thank you, Masoud, and welcome, Jean-Christophe. It has been a while, almost 3 years now, since we left Montpellier. It's nice to see you again, really. Just my question to Masoud. Welcome back. The question to Masoud, is there any more study emphasizing the therapeutic option of EUS RFA, especially in neuroendocrine tumor? Because, you know, sometimes in neuroendocrine tumor, if it is in this distal part of the pancreas, it's easy to go and do distal pancreatectomy. Whereas in the head of the pancreas, really, I mean, we don't prefer to do Whipple sometimes, unless really, I mean, indicated, especially in young people. Okay, so in this study, does they really emphasize in the therapeutic option as a therapeutic option in neuroendocrine tumor?
So most of the studies, they give optimistic results in the management of the pancreatic and neuroendocrine tumors. Even in most of the studies, 90% to 100% ablation. I've reviewed another systemic review with meta-analysis regarding the neuroendocrine tumors. They give also optimistic results, but I don't think yet it is in the guidelines.
Okay, thank you, Mr. The floor for you, Isa.
I have a question.
Yes, please.
Yes, it was a very interesting presentation, but there is a long time of the study are over 10 years. And did you know it's always the same tools used, or if it's RFI from different manufacturer? And I know a little the series of Marc Barthé. And I know that during his study, he has changed the procedure. After complication with the beginning of the study, he put systematically anti-inflammatory
anti-inflammatory drugs, yes.
Yeah, anti-inflammatory drugs during the procedure. And so he will put a pancreatic stent if he's very short from the pancreatic stent. So the question is it's a homogeneous series, or it's a very large procedure and tools used during this article?
John Christophe, you mean they put the stent to protect the duct during the RFA? The aim?
Yes. If the destruction of the nodules is near from the pancreatic duct, they put a stent to protect and to prevent the structure of the reversum. But they have to adapt their protocol during the study, and that's why it's very heterogeneous series on literature. It's one difficulty to make a meta-analysis with all these cases.
Okay.
The question of that as well, these cases, for example, where we think they are eligible for endoscopic treatments, are they making like a significant percentage of the all cases? Because usually, like for example, 2 centimeter and above, usually we say resections. Grade 2 and 3, we say resections. I would say, or like with suspected lymph nodes, we say resection. These lesions, which are, I would say, close or in contact with the pancreatic duct, we say resections. So I don't know what's the percentage of cases which will remain for endoscopic treatment, which will be the ideal, I would say, cases. I don't know, as a surgeon, I would say probably a case who is not operable, but I don't know, what do you think?
Of course, the majority will be the patients with a lot of comorbidities and inoperable patients, but I think it is very emerging technique and procedure, and probably it will take its path to be like what we are doing for small liver lesions. We can RFA the lesion and even RFA the tract if we are afraid of metastasis into the tract where we punctured. But nevertheless, it is taking its place now as a procedure which is well established, and it's getting its own protocols. As Dr. James Baltas said, now the new protocol is you put the pancreatic stent if the lesions are close to the duct, and you are afraid you might RFA the duct as well. Also, you give the NSAIDs to prevent pancreatitis. That's another a way of preventing pancreatitis and complications. You can hydrate the patients well before the procedure and after. That's all will prevent the complications. But if you think about it, for small lesions, will you go for a big surgery or we will go for a minimally invasive procedures? We can always debate. Surgeons want to carry on with their work. We want to also take some procedures from you guys, and it will always be debatable.
Yeah, as you said, Dr. Isa. And probably the discussion main will
we have a reverse situation. So before was the surgeon and the gastroenterology endoscopist was the second steps. Now is the endoscopist the first and the surgeon the second step, because we received a patient from Marseille. He underwent to thermoablation of neuroendocrine tumor less than 2 centimeters, but with chronic fistula of the pancreas. So finally, we performed a distal pancreatectomy. So we changed the situation. Now the endoscopist become a surgeon, and the surgeon the gastroenterologist. So is this is the future is that. So I leave Jean-Christophe.
And then maybe it will go back again to the endoscopist.
Yes, maybe, yeah.
Then I think we will end this discussion here, and we will go for Dr. Jean-Christophe Voltas. He is a gastroenterologist and a hepatologist in a very busy center, and he is having a wide experience with gastroenterology and hepatology and liver transplant patients. He's going to present cases today for us, and we would like to have him here and sharing his experience with us. So please, the floor is yours.
Could you see the slide or not?
Not yet.
And now?
Yes.
Yes.
Good.
So, good evening, Sultana of Oman. So I'm Jean-Christophe Valat. I'm a gastroenterologist in Montpellier University Hospital. And thank you for the invitation. I will talk about an interventional case of endoscopy. Let's begin. The case is Mr. L, 76 years old. The medical backgrounds are type 2 diabetes with complication, arteriopathy of the lower limbs, mid-chronic renal failure, and obesity stade 1. The patient is also followed for GERD for more than 5 years, and he was explored by gastroscopy in secondary hospital. So the gastroscopy described long Barrett esophagus, and untargeted biopsy shown a non-nodular bifocal high-grade dysplasia. So the patient was referred in Montpellier Hospital for a new endoscopy of confirmation of the histology and for the management. So we use an Olympus high-definition gastroscope and the exploration with a white light and narrowband imaging. So first, we describe the Barrett esophagus according the Prague criteria, and the circumferential extent was 8 centimeters, and the maximum extent was 10 centimeters. With careful examination the Barrett esophagus, and we did not show any nodular lesion. But the screening of the mucosa allowed us to identify 2 suspicious areas. The first is here with destructured mucosa, dystrophic gland at 38.9 hours. And a second size area here, it's 36 hours with a dystrophic gland and irregular pattern. So as it's recommended, we use also a CO2 protocol, which require biopsy samples every 1 to 2 centimeters in 4 quadrants, and suspected lesions were targeted. So 1 week after this endoscopy, we had a first surprise with the pathological finding. So the surprise is that we have greatly underestimated the dysplasia. The 2 sites suspected were high-grade dysplasia, but the pathologist described and revealed 21 additional high-grade dysplasia foci. So what are the treatment options? In the case, if I summarize, it's a patient with a Barrett esophagus with a multifocal, non-nodular, high-grade dysplasia. We have the choice between 2 strategies. The first strategy is a minimally invasive strategy with endoscopic destruction of Barrett esophagus. It's the strategy was recommended by the European statements, and we can read that if biopsy confirms the presence of high-grade dysplasia, endoscopic ablation is recommended, and preferentially with radiofrequency ablation, another application of radiofrequency in gastroenterology. But this kind of destruction is destruction without an histological sampling. The second choice is surgical treatment with Lewis and Pitti surgery. It's a curative treatment with a high-level histological analysis, but it's associated with high morbidity and potential mortality. So this patient file was presented at an oncology multidisciplinary meeting. Personally, when I present this patient, I preferred surgical management because of the extensive dysplasia. But the endoscopic destruction was chosen because of the patient's age and his vascular comorbidity. So the meeting recommend also to complete the pre-therapeutic assessment with a CT scan, PET scan, and also AUS exploration, looking for invasive parietal lesion of mediastinal lymphoadenopathy. The CT scan did not show any suspicious mediastinal lesion. The PET scan did not identify any suspicious hypermetabolic lesion. And finally, the endoscopic ultrasound did not show the parietal lesion or mediastinal adenopathy. So the endoscopic treatment were therefore confirmed. What endoscopic options are currently available for this case? There is endoscopic ablation without histology or endoscopic ablation with histology. The endoscopic ablation without histology includes minimally invasive procedure, simple technical improvement, well tolerated and associated with a low risk of complication. The main limitation of this technique is the absence of histology sampling. So we can talk about radiofrequency ablation with destruction of Barrett esophagus with radiofrequency application. A second option will be a hybrid APC, plasma argon coagulation with a catheter to destroy the mucosa. And a new tool is actually available. It's a cryotherapy ablation for the destruction of Barrett esophagus. The endoscopic ablation with histology are more invasive procedure with technically complex and associated with a higher risk of complications such as perforation, hemorrhage, of occurrence of secondary stricture. One of these techniques is mucosectomy with cap or a multi-band mucosectomy, use a rubber band ligation cap and polypectomy snare. The second option is ESD or endoscopic submucosal dissection. This technique allows the digestive mucosa to be cut But in these clinical cases, this will require an extensive circumferential resection of Barrett's mucosa. So in this case, in favor of RFI, it's a technique which is recommended by the ESGI, and there is a low risk of secondary structure. But there are no histology, and we have to treat a multifocal high-grade dysplasia. There is also a theoretical risk of buried dysplastic glands. For cryoablation or hybrid IPC, the limits are the same. For mucosectomy, in favor of this technique, there is histological analysis, but again, there is a risk of mucosa bridge with dysplasia and an elevated risk of structure. And the last technique, ESD, in favor of this technique is a high-level histologic analysis if we do an in-bloc resection, but there is a high risk of secondary structure. So we choose to perform an extended circumferential dissection of all of Barrett's mucosa. We wanted to focus on histologic analysis. The patient was informed of our therapeutic strategy. He was notably notified the high risk of stenosis structure and the need of potential secondary endoscopic dilation, but he approved the treatment. So we performed the extensive circumferential dissection of the Barrett's mucosa. We use an Olympus dual knife G, and we start with an oral esophagus circumferential incision, and then a second subcardial circumferential incision. We connect the incision with 3 tunnels, and we use also clips and wire traction to facilitate the procedure. This is on the left side, the oral incision of the Barrett's esophagus, and in the right side, the scar after resection of all the Barrett's mucosa. And here is the final dissection piece, arranged and oriented on a syringe. It was a very long procedure, above 3 hours. We have to make a step-by-step hemostasis using a monopolar forceps, and there were no perforation. So we have to wait the final histologic analysis, and for us, it was a second bad surprise, because there is expected results, a diffuse Barrett's esophagus extending all over the entire resection with foci low-grade and high-grade dysplasia, but there is an unexpected result with a well-differentiated infiltrated adenocarcinoma focus, extensive intramucosally and focally extensive on the submucosa, SM2. The lesion was classified T1B R1 because the deep margin was over 1 millimeters. So finally, the patient was referred for surgery. Secondary, 1 month later, patient have sign of structure, and we do an endoscopic esophageal balloon dilatation. No additional dilation have been scheduled because the patient will have surgery soon. So this is the end of my presentation, and this is the conclusions. So endoscopic evaluation of Barrett's esophagus still is a difficult procedure. We make several samples of Barrett's esophagus during 2 endoscopy and 1 echoendoscopy, but we fail to identify the adenocarcinoma. How can we improve? Perhaps with using existing tools like endomicroscopy confocal, but it's depending on the training of the operator, and there is a large surface to analyze with a small catheter. Perhaps new tools of artificial intelligence associated with endoscope will soon help us to identify areas with dysplasia. The conclusion 2 is endoscopic ablation with ablation of Barrett's esophagus without histology are effective, safe, but especially in this case, we cannot have diagnosed carcinoma. It is a complex case, and the complex case of dysplasia must be assessed by expert team, and discussed in multidisciplinary committees. So thank you very much to invite me. I will give special thanks to all the digestive endoscopy team in Saint-Éloi, and especially Dr. Combe, my partner to perform the ESD. So I will thanks to Abdallah Al-Fahai, Fabrizio Panaro, and the HBP Coffee for the invitation. Thank you very much.
Thank you. This is very interesting indeed. Very nicely presented case. Unfortunately, the second bad news was really bad because he has to go for another procedure. But the case is open for discussion because we do face similar cases as well from time to time. And of course, like, you know, it is very difficult to go for histological ablation or non-histological ablation, but I agree with your conclusion because I usually like the histological ablation because it gives us more comfort after we get all the histopathology, but not every patient will be fitting for such a prolonged procedure or comorbidities like for the strictures and perforation bleeding after the ESD. The floor is open for comments, discussions.
Yeah, again, a reminder, just for security reasons, the mic is blocked. And if you have any question, please let us know by raising hand or put it in the chat, and we'll let you speak. Just waiting for the others. Jean-Christophe, I don't know, what do you think? Was there a lose of chance, for example, for such patient who went for endoscopic, I would say, intervention, and then at the end went to surgery? Was there any lose of chance, or I would say the final outcome result is same?
J'ai pas compris ce qu'il me demande.
Il a perdu de la chance en fait.
No, I don't think there is a loss of change if we start with mini-invasive techniques, and we have choose an histologic ablation. So it will be a loss of chances if we don't have done an histologic ablation, because we have ignored adenocarcinoma, and this adenocarcinoma could have worse development. So in the case, there is a stricture, but the stricture will be treated with surgery, and it's a starting lesion, a starting carcinoma. So a patient has the chance to be cured with surgery.
Thank you.
Abdullah, the upper GI surgeon.
Yeah, hi,
comment or not? Hi, Abdullah.
Hi, good evening. Thank you very much, Dr. Barat, for your presentation. Very interesting case. I personally agree with your approach, the way you did it. First of all, I think we should always have histological confirmation. We cannot just ablation. It's not a simple Barrett's esophagus. We have high grade dysplasia. So, and the proof we have actually the final pathology, an invasive carcinoma. The other thing is also that your choice of doing actually submucosal dissection is very important, because the surface area is really large, and the problem with just doing mucosal resection, it's very good for small lesions, but for really large lesions, you need to have the endoscopic submucosal dissection gives you better idea about the depth of the lesion more than the mucosal resection. Now, my question to you, since it's a large lesion which you took, why in this patient, we knew already that the stenosis risk is really high. Was not there a place for like a preventive stenting of the esophagus after the resection? This is just one thing which is I'm really not very sure of, because we knew almost sure that he will develop the stenosis. Yeah, the other question is, since you send the patient to a surgeon, I would really be curious about what happened to this patient. Did he underwent actually this surgery, the Ivor Lewis? Did he do well, or knowing that his real background is really very bad, diabetic, vascular disease, and chronic kidney disease?
So for the answer of the first question, I don't think that we can prevent efficaciously the stricture with a stent. Stents are very aggressive in the esophagus and there is no mucosa, only muscle, so there is a high risk of complication with stents. There are some technique to prevent the stricture. It could be a corticoid injection in the wall, or budesonide treatment, like with eosinophilitis with budesonide inhalation. So it's just some cases in the literature, but we don't have any efficient tool to prevent this stricture. So usually there is an efficacy with balloon dilatation in these cases. So that's why I choose this technique, and I inform the patient that he will have after a USD balloon dilatation. For the second question, the patient is not also already operated because we have to make another assessment. We'll have another CT scan, another PET scan, and after I will give you information and lead to a surgeon. I think that we will have a Lewis anti-surgery.
Okay. Thank you very much.
I just want to ask you if you do preventative dilatation, like you call the patient after 1 week and do preventative dilatation rather than waiting for the stricture to form, because we usually like to have this approach. It might be easier to treat these strictures than waiting for them to form and the patients start to have symptoms, and then we go and dilate them. What is your intake into that?
So the patient was convoked 1 month systematically after USD to have an endoscopic look and to treat as soon as possible the stricture. So we don't wait stricture or clinical symptom to have a new endoscopy.
Yes, that's usually the approach we are following as well. Any other comments, questions from the audience?
Yeah, again, please, if you have a question, raise your hand or put it in the chat, and we'll let you speak. Again, we apologize from the part of Dr. Mark Giovannini that he's absent because of an emergency situation from his side. Unfortunately, he could not join us for this Zoom meeting.
Good. I think we could.
Jean-Christophe, je sais pas. Sorry, do you have, I would say, a lot of such patients in the south of France? Because we know, like esophageal lesions or esophageal, I would say, cancers, we found them, I would say, a lot of them, for example, in the north of France. I don't know. Do you see them frequently in the south as well, or how is the situation there?
No, it's the same repartition in the south or in the north of the country.
We have a question from Dr. Sliman Mamri. He's a senior consultant HBP surgeon in Royal Hospital. He's asking if perforation occurred during resection, any endoscopic management can be done?
Yes, yes, we have efficient tools to treat perforation. We can use clips or Ovesco clips. It's a larger perforation, and also in these cases we can try stents to treat an eventual perforation. But it's not elevated risk. There is the possibility to dissect the esophageal mucosa, and we did this procedure when we make a treatment of achalasia. So it's it's a small risk procedure for perforation.
Another question, probably not related to the case. What's the experience of, I would say, mobile experience with the endosponge for like, I don't know, anastomotic leak, whether esophageal or rectal?
So we use endosponge to treat a large defect of the esophageal walls. It's an efficient treatment, but it's a very, very long treatment with several endoscopy. We have to make 2 or 3 endoscopy in week, and during 1 or 2 months to have good results. So it could be an option, a therapeutic option, but first we try other technique like stents or double pig drainage if we have a esophageal wall perforation. So it's an option, but very, very full-time option.
Okay.
Just is a question outside of the field, but what is your attitude in case of pancreatic fistula, which is your first step? Stent position or Jean-Christophe?
It depends the type of surgery. It's a distal pancreatitis without a larger collection. A stent will be the first choice, but if it's a larger hydric collection, so gastrocystostomy will be short.
Yeah.
And sometimes we have to make the twice treatments, pancreatic stent and also pseudocyst drainage to have the best results.
And what about the injection of the prophylactic injection of botulinum?
Yes, it could be an option, but it's a pre-therapeutic treatment before surgery. We can paralyze the OD sphincter with a toxin botulinic injection. And so it will favorize the puncture fluid in the duodenum after a surgery. And if there is a fistula, some puncture-thick fluids can go directly into the duodenum. So we will start a clinical evaluation for this toxin botulic injection prior surgery of pancreatic of distal pancreas. Do you have some experience about this new protocol with the toxin, botulinum toxin?
No, not indeed. I haven't used it before. No.
No, I think it's interesting because it's easy to do. Yes.
Yeah. Definitely. Like, we'd like to. If you want, we can participate in this trial as well. We can also do it.
Yes. Okay. Oh, thank you very much, everybody.
Thank you. We are really pleased to have you with us in our cafe, and hopefully we'll see you soon.
Okay.
Thank you very much. Thank you, Jean-Christophe, for giving us part of your time and sharing the case with us. Interesting.
Thank you for the invitation. It was a pleasure.
He's a very busy man, more than me. Very busy. Jean-Christophe, it's not easy to find, huh?
And
No,
thank you.
he's always
Yes.
busy. Huh? We know him.
Yes, every day.
Yeah.
And thank you,
Yes.
Mr. Wood, as well, for the nice presentation and analysis of the article. And thank you, Dr. Isa, for moderating the session. And again, thank you for all the participants who were there today with us. And again, we apologize from the part of Dr. Mark Giovannini for the emergency situation that he had. He could not join us for the session.
Yes, next time.
Next time, exactly.
Yes.
It was a very interesting subject.
Yes.
The gastrointestinal anastomosis and the atypical drainage after surgery or of oncology situation.
Yes.
So it's a very interesting subject.
Yes. We're waiting for the next time.
Yeah, soon.
Yes.
Okay. See you. Bye. Thank you.
Right,
See
Bye.
you.
Bye.
Have a good night.